Welcome to an HIV Center Grand Rounds. Today's a little bit unusual in that we're having it on a Tuesday morning. We also have 4 people. We're lucky to have 4 people presenting with us today. So for today, we're going to have 4 folks from the Department of Health and New York City Department of Health and Mental Hygiene, and also Columbia University Medical Center, talking about the New York City Health Department's HIV self-testing initiatives to increase access among priority populations. Before we start, I'd like to give everyone an announcement of our upcoming Grand Rounds. On this Thursday, so just 2 days from now, we have Dr. Taraz Samandari talk from the CDC, talking about responding to Kenya's COVID-19 pandemic whilst preserving progress against HIV. I think very important, very timely for the times that we are in. And then during World AIDS Day week, our rounds that week for World AIDS Day will be from J.D. Smith from University of Utah School of Medicine, titled Implementation Science in HIV, Where Are We Now and Where is the Field Going? So it's with great pleasure that I introduce our panel. I'm going to do a brief introduction for all 4 people, and then our first presenter, Zoe Edelstein, will be kicking off. We'll have a very brief Q&A between each of the presentations, and then we are planning on some time for discussion at the end. So as always, keep yourself muted during the presentations. Please feel free to put any questions you have in the chat as they come up for you, or you can even just simply place your name and we'll call on you at the time to actually ask you a question if you want to do it verbally. And for people who are on a phone and not on Zoom, they can speak up at the time if they have a question. But again, people can put questions in the chat. Okay, so we have 4 people, as I said. Our first will be Dr. Zoe Edelstein, who is the Director of Research and Evaluation for the HIV Prevention Program within the Bureau at the New York City Health Department. In this role, she oversees the preventions program research and evaluation work, including evaluating activities and contracts, monitoring citywide trends, and conducting special projects. And these include, as going to be talked about today, New York City's online home test giveaway. Dr. Edelstein received her MS and PhD in epidemiology from University of Washington. And we're proud to say she was a postdoctoral fellow, did a postdoctoral fellowship here at the HIV Center at the Psychiatric Institute at Columbia University. Next up, we'll have Dr. Lawrence Purpura, who is an attending in the Division of Infectious Diseases at Columbia University Medical Center here with us. He is a recent graduate of CUMC's Clinical Infectious Disease Fellowship and ICAP's Global HIV Implementation Science T32, where his research focused on HIV self-testing and improving provider screening for HIV and sexually transmitted infections. Prior to his fellowship, he was a CDC Epidemic Intelligence Service Officer, where he provided epidemiological support to CDC's 2014-2016 West African Ebola outbreak response and the Liberian Ministry of Health's nationwide semen testing program for Ebola virus. His research interests now are focused on studying long-term sequelae of COVID-19. So clearly, very timely topics that our panel are engaged in timely domains and important domains. Then we have Stephanie Hubbard, who is the director of the program planning for prevention program in the Bureau at the New York City Health Department, where she leads the development of programmatic models for client-centered, affirming, and culturally responsive data-driven HIV prevention service delivery using a health systems and design thinking framework. Stephanie is a graduate, again, of our home institution, Columbia University Mellman School of Public Health, where she earned a Master of Public Health in Health Promotion within the Socio-Medical Sciences Department. She also holds a Master of Arts in Sexuality Studies from San Francisco, and her previous work was as a consultant with the International Center for AIDS Care and Treatment, ICAP, as the Assistant Director of the SIDHART-E program, which is a joint initiative between the Ministries of Health in Rwanda and Ghana and Columbia University. And then finally, we have Maria Ma, who is a senior program planner in the Bureau of HIV at the New York City Department of Health and supports the prevention program in development and prevention programming, coordination of quality improvement activities and pilot projects. Maria also leads the day-to-day operations of the Community Home Test Giveaway Program, which recently helping to launch the CHTG virtual program in March of this year, 2020, which was in response to COVID-19. Maria is a graduate of the Yale School of Public Health, where she earned a Master of Public Health with specialization in epidemiology of microbial diseases. So again, this panel will be talking to us about the New York City's Health Department HIV self-testing initiatives to increase access among priority populations. And I will now turn it over to you, Dr. Zoe Edelstein.
Hi, good morning, everyone. I'm going to share my screen. Can you see that okay?
Yep, looks great.
Okay, great. It's such a pleasure to be here, to be back, even though we're in the virtual space, and we are so delighted, my colleagues and I, to present to you. Just for a little rundown of the presentations that you're going to see, and thanks so much for the kind introductions, Bob. I'll first be presenting on the self-test program, the online program that's been ongoing since 2015. And then Lawrence will be presenting on an analysis within this program, a very important one, looking at those that have repeat participation between the waves, which I'll define in just a little bit. And then the third presentation, a very crucial presentation about different home test giveaway, the community home test giveaway that's led by Stephanie and Maria, and importantly, how it's adapting to this COVID-19 environment. So just to get started, so this first presentation again is on New York City's online home test giveaway from 2015 to 2020. And by way of some background that may be very well known to people on the call on HIV and testing in New York City has one of the largest HIV epidemics in the United States, with just under 2,000 new diagnoses in 2018 and more than 27,000 people living with HIV. Among others, there is a very high burden among men who have sex with men, or MSM, and transgender individuals. HIV status awareness is a key component of both the national and New York State ending the epidemic plans. It's known as the diagnose pillar in the national plan. And in New York City, HIV testing rates are high as a result of programs that we've worked on, as well as many of the people on this call, and as well as the obviously the individual work by New Yorkers to get themselves tested. But there is still room for improvement. For example, among adult New Yorkers, 34% report never testing for HIV. And among men who have sex with men who participated in the National Behavioral Surveillance Survey, NHBS, 19% report not testing in the past year. So enter the self-test, which I've, throughout this presentation, I'm going to abbreviate as HIVST. As many of you may also know, the FDA approved this test in July of 2012. It's over the counter and a rapid test for personal use. It helps address barriers in testing, including concerns about privacy, stigma and hesitance to seek testing in the clinical environments. However, there are potential barriers to self-test use, including awareness, whether folks know about the self-test, the price, which the retail price is approximately $40, and availability. In New York City, for example, one study showed that it was only available in 1 in 4 pharmacies. So to address these self-test barriers and to promote HIV testing awareness in general and HIV status awareness, there are some giveaway programs. And as of 2015, which is when, again, we launched our pilot program, there had already been some giveaway programs in Los Angeles, Washington State, and London. So in 2015, the New York City Health Department launched its online home test giveaway. The goal was to distribute self-tests to MSM and transgender individuals who have sex with men. The tests were sent at no cost through the mail, and it's conducted entirely online. and also importantly informed by community stakeholders, including our HIV planning group, or HPG. After a successful pilot in November of 2015, 6 more waves of the HCG have been conducted. These all use a similar model plus some innovations, including adding more kits to the inventory and broadening our reach of marketing. So I'm just going to walk you through the flow of the home test giveaway, the online home test giveaway for participants. They first view a digital ad and they click to an eligibility survey. Then they answer some basic eligibility questions. If eligible, they receive a discount code in the email immediately, and they are directed to the manufacturer's website to place an order. If not eligible, they're directed to other resources. Once they have placed their order, they receive a test package in the mail. It's in a nondescript brown box, and it includes the test as well as 2 postcards that have been developed by the New York City Department of Health. That's one talks about HIV testing, including what to do if you test positive, and the other postcard is about PrEP and PEP. Then about 6 to 8 weeks later, they get a follow-up survey by mail. So just a little bit about the eligibility survey. It's assessed through an online survey. Includes all of the following: being a cisgender male or transgender or gender non-conforming individual, having sex with a male in the past 12 months, residing in New York City, age 18 or older, and no previous HIV diagnosis. And then the only other data collected is on race, ethnicity, and time since last test. The whole thing lasts about 3 minutes, maybe 5. Then the follow-up survey is sent to all eligible home test giveaway participants. Data is that's collected includes whether they receive the test, use, experience, results, as well as recent HIV-related behaviors, and participation is incentivized by a $25 gift card. So I'm going to talk about waves a few times during this. So what is a wave? So a wave is basically the amount of time of this limited time giveaway. So each one lasts about 3 to 6 months. So first, there are recruitment ads that are only out for 4 to 8 weeks. Then the kits are sent for about 2 extra weeks, so 10 weeks total, and then the codes expire. Then we wait 4 to 8 weeks, and then there's a follow-up survey, which is out for 4 to 8 weeks. So in total, as I said, the waves are about 3 to 6 months, and we have done 7 so far. So today, the data that I'm going to highlight are across all 7 waves. When we're talking about participation and the flow of activities, the characteristics of participants, home test giveaway, self-test use and results, and acceptability of the home test and the home test giveaway program. This is just a small bit of the amount of data that we have, and I'm very happy to share it and also answer any questions at the end about other areas. So just to start out with participation and home test giveaway distribution. So over the 7 waves, those bars are in blue, and the ones in orange-ish are the mean across the 7 waves. So in total, there have been over 37,000 screenings to get into this home test giveaway program with an average just above 5,500 per wave. And there have been 23,506 deemed eligible, which means 61% of those who took the survey were eligible. And then in terms of redeeming the code that they get sent, there have been 16,762 redemptions. In other words, we've sent out over 16,000 self-tests through this program. And that's 71% of those who are eligible redeem their code. So looking at the age distribution among eligible participants, here you're seeing each row or each bar here is one wave. So through waves 1 through 7. So 1 is the pilot wave that happened in 2015, and 7 is the most recent that happened in 2020. Both the blue and the orange bars include those who are between 18 and 34, and you can see that's by far the majority of participants in this program, although there are some who are older than that as well. Across the waves, this is race ethnicity, so a similar type of graph here. And you can see in blue, these are Black participants, in orange, Latino participants, in gray, Asian and Pacific Islanders, in yellow, multiple races, and those who check other, and in blue, darker blue, white. And so you can see here that across the waves, Black participants have been between 14 and 19%, and Latino or Latina participants between 30 and 36, and combined just around wave 5, we started getting the two groups together as over 50%, but that is only increasing very smallly between each wave. This is gender across waves. By far, the majority are cisgender men, but TGNC has been increasing to a degree. So for the last wave, there were over 100 TGNC participants. This here shows prior testing among eligible participants, and the number in bold is the mean across the 7 waves. So the mean across the 7 waves, 18% of participants report never testing before participating in the home test giveaway. And then if you look at the green piece of the pie, an additional 22% state that they have not tested in the last year. So in terms of, so that all came from the distribution phase, and now I'm going to talk a little bit about data from the follow-up survey. So 46% on average of eligible participants responded to the follow-up survey, and among them 91% received a test, and among them 81% used their self-test, and among those 74% used it pretty quickly in the first week. These are the test results as reported by participants who reported their test results. So about 66 across, or exactly 66 across the 7 waves have reported reactive results for seropositivity of 0.9%. And in terms of new diagnoses, people who said they have never tested for HIV, positive for HIV before, 51, so a seropositivity rate of 0.7%. Among them, most but not all got a confirmatory test. Almost all who tested positive in the confirmatory test reported having an HIV care appointment. And at the time of the follow-up survey, among them, 81% reported starting treatment. So this is a little bit about the acceptability as measured by the follow-up survey. The first two show that the things that folks most liked about using the self-test, which were convenience and privacy, which really confirms some of the formative research that we did before starting. But still, folks are not yet willing to pay $40 for the self-test. So it shows that this is really filling, this program is really filling a hole. And importantly, people really seem to accept this method as measured by reporting being likely or extremely likely to recommend HTG to a friend. So 98% of the participants who participated in the follow-up survey on average reported being either likely or extremely likely. So some limitations of these results: the data is self-reported and thus subject to social desirability bias, recall error, and misinterpretation. The data from the follow-up survey may not be representative of all HTG participants. Remember, that was only 46% of them, although that was a percentage that was higher than we were expecting. And so we're very glad for those who did participate. And then, of course, the results of this giveaway may not be generalizable to other settings. So just to summarize, over the 5 waves, we've distributed a large volume of self-tests. The findings were consistent over 7 waves, including a diverse group of folks, testing people who may not be otherwise reached for self-testing. And the success of these ways have led to use of the model in other ways, including expansion with a partnership, capacity building to other jurisdictions. And in addition, the limitations of the model, including not reaching those who may not have been reached online, including as well as this program being specific to MSM and TGNC and giving away self-test only, has led to the New York City giveaway, other New York City home test giveaway programs, as well as discussion of future projects. I just want to lead off for the other two presentations to say that we have found also that HCG is more than a free test. It encourages people to know their status. It reaches individuals not yet served by HIV prevention services. And among other things, establishes a virtual connection with the community and can help New Yorkers live their healthiest sexual lives. There are so many people to thank, as you can see on this slide, and I look forward to any questions that you may have. Thank you for your kind attention.
Thanks, Zoe. We have a question from Stephen Sawicki. Stephen asks, has the data been compared against nose data? If so, any similarities or differences? Stephen, perhaps you can unmute and describe to us who are unaware what the nose study is.
Sure, happy to do that. So New York Nose is the big testing initiative in New York City. It's present in all the boroughs. It's been around for, probably a decade or so. Started in the Bronx Nose. And they have collected, especially over the last 5 years, a lot of data around testing and have done a lot of testing. And I'm just curious as to how this data compared with, if you've compared it, how it compares with that.
That's a really great question. I don't have those numbers on hand, although I do see them. And the New York Nose initiative is a very important part of New York testing in New York City. And I think it's important to say here, although it's not quite the question you asked, that these online home test giveaways, as well as the giveaways that we do, are meant to be in addition to the programs that have been established, including New York Nose. So just basically throwing everything we can at the diagnose pillar to make sure we get folks tested. So the short answer is no, I haven't done the comparison in numbers, but I do think they do complement each other. And I will look into it.
Stephen, do you want to go ahead and ask your next question?
Yeah, sure. So I had two actually. And I was just curious, you'd mentioned that you had a mean average for people in the 7 waves. I think you said who had not been tested in the past year. Mm-hmm. Do you know how many people in the 7 waves, and maybe you don't collect this, said they had not been tested ever?
Yes, that was the first statistic, the 18%.
Oh, okay. Okay, yeah. So that was 18.
Which is higher than a lot of our other non-self-testing programs.
Yep. Thank you.
Great. We have a question from David Matthews. David says, my apologies if I missed this, but what criteria would make an interested individual ineligible for the project?
Sure. Someone would be not eligible if they were not a cisgender male or a transgender or gender non-conforming person, if they were under 18, if they had been already diagnosed with HIV, or if they did not live in New York City.
A question from Gina Wingood. Among those eligible but did not receive a self-test, how could you improve adoption of a self-test who are eligible?
The people who didn't redeem their code for
exactly.
a test?
Yeah.
That's a really great question. I would love suggestions. What we've done that has really helped, I mean, it's so basic, but lots of reminders.
Sure.
And then of course, when people have questions about like whether, like what, if they're having problems in any way, we have a email address that's very accessible. It's actually the same email address that the code gets sent to them. It's managed, the replies are managed by a person on our team. And so that can help with any technical issues. Of course, OraSure has their own hotlines for that, but there are going to be people obviously who drop off for any number of reasons and decide not to redeem their code. We do have questions on the follow-up survey that I would be happy to look into. I haven't looked into recently about among those people, but it just, I mean, maybe this is predictable, but the people who don't redeem their codes are also less likely to participate in the follow-up survey. So it's not a very big group.
It seems like they may be contemplating a test, maybe potentially as well. And they might be, I don't know, maybe riskier. I have no idea, but it might be, who knows? It might be interesting, you know, how could you potentially reach those people?
Yeah, that's a very good idea.
A question from Rose Chestnut. Rose, feel free to unmute.
Good morning, everyone. I'm with Caribbean Women's Health Association, and Maria has been so graciously taking me through the steps, and I've gotten through those, and she's came back and trained a couple of my colleagues. However, since doing the home testing, I'm with, like I said, Caribbean Women. Since doing the home testing, the problems that we're having are when I ordered the kits for them, they're not getting the kits at home. And then that leads me to going back to Maria, and then she has to find the tracking numbers, and she tracks it. And then she also sends the tracking numbers to me. And then we go, you know, we have to wait again for them to get their testing. So since then, I've actually ordered the test to come to the facility and they pick it up. But that's not the whole purpose of the home testing. The home testing is to get them at home. So is there an easier way that we can facilitate to move this process along and not have people have problems getting their testing?
That's a great question. I'm gonna pass that off to my colleagues who work on the community home test giveaway.
Sure. Thanks, Zoe. Thanks so much, Rose, for your question. I think Zoe's program with the home test giveaway, and then you'll hear about the community home test giveaway, are just a few, it's kind of like a slate of different programs that we have in order to utilize the HIV self-test kits to get them out. So while I think your question is a really good one, and I think we need to talk about it offline a little bit more about, you know, the offering different ways in which people can access the HIV self-test kit. So whether it's, you know, at your agency, at a pharmacy, at being mailed to your home or to a different location, having a small business have them available as well, are all different options that we're exploring so that people can get access to the kits as quickly as possible and in the way that they want to. But I'll definitely reach out to you and make sure to touch base with you a little bit more about that.
Okay.
And so I think we'll move on to Lawrence's presentation now.
Yes. So Lawrence is going to be talking about an analysis that he's done within the online home test giveaway. And I just want to mention Lawrence has also been an amazing analyst on our team, and I'm just so grateful to be working with him.
Thanks for those kind words, Zoe, and thanks for the wonderful overview. So I was given a very wonderful opportunity to work with Zoe and the rest of the HIV prevention group on the home test giveaway during my time as both an ID fellow and also an ICAP Global HIV Implementation Science Fellow. And it was a wonderful opportunity. And as Dr. Remien mentioned in the introductions, prior to fellowship, I was working with the Liberian Minister of Health on a Ebola semen testing program for prevention of sexual transmission of Ebola virus. And what attracted me to the project that we're discussing today is there's a lot of similarities. You know, they're both public health interventions that involve longitudinal work and, you know, really are targeted at providing services to harder to reach communities. And the one thing I really love about this type of work is being able to still obtain data and to use data to drive both monitoring and evaluation and implementation, but also to answer unknown questions. So one of the questions that I had when I started working with the data was, who are the people that are utilizing the home test giveaway on more than one occasion? And are there specific things about their demographics or their sexual health background or behaviors that could be used to help inform the home test giveaway? So that's going to be the analysis I'm going to present this morning. So the objectives of this specific analysis, first of all, is to identify participants who have utilized the online arm of the home test giveaway on more than one occasion. And the second objective will be to describe overall demographics as well as sexual health characteristics across the multiple waves. So regarding methods, the first step was to merge all 7 waves of the home test giveaway to make sure that all the variables were compatible. And then I performed a matching based upon email. And it's important to note here that when the participants sign up for the home test giveaway, it's not as if they're signing up for some sort of research study. That's really more of a voluntary program, a service that they're signing up for. But through email matching, we were able to determine who had participated in multiple waves over the 7 waves. So this analysis was restricted to people who both redeemed an HTG code and also who completed the follow-up survey. And I also want to highlight and just emphasize that this analysis is conducted at the observation level. So that means that for a participant who participated multiple times in the giveaway, for the sake of the analysis in terms of sexual health outcomes, they will be counted more than one time. So again, this is at the observation level and not at the participant level. And for the analysis I'm going to show you, the methods I used were just to perform descriptive statistics on demographic data, and then we'll review a chi-squared analysis performed on sexual health questions specifically. So this table shows the number of repeat participation across all of the waves. And I think I'll just start by emphasizing the bottom row, which is the sum. And you can see that there was a much higher rate of multiple participation than we were expecting. So the column on the left is the proportion of multiple participation amongst those that redeemed a code, and the column to the right is for those that both redeemed and completed the follow-up survey. And you can see that over 9,000 of these observations were in the setting of repeat participation. So I think just in general, this says a lot in terms of the acceptability of the home test giveaway, which I think is quite impressive. So just to further delineate what this is showing. So for example, in wave 1, there were 833 of the participants that went on to participate in another wave of the home test giveaway. And nearly 500 had also completed the follow-up survey. And likewise in wave 2, there were over 1,000 participants who went on to participate in a subsequent wave or participated in wave 1. And then I already highlighted the fact that overall, there are many, many people who participated multiple times. This next table shows the total number of waves that each participant joined. And you can see that over 1,600 people had participated in 2 waves, and nearly 600 people participated in 3 waves. And although the overall percentages aren't high for people who participated in 4 to 7 waves, if you look at the gross numbers, we're still talking in the magnitude of several hundred people that had participated in many waves over the years, and even some people that participated in every single wave. So I think, again, this speaks to the acceptability of the home test giveaway. And now I'll describe demographics comparing a new observation versus a repeat observation. So for in terms of age, there was a similar age distribution with a mean age of 31. For gender, they were also fairly similar with 98% of repeat observations identifying as cisgender versus 96%. We did see more of a difference in terms of race and ethnicity, whereas repeat observations had higher proportions of people who identify as both Black and or Latino or Latina. So I think this highlights that we may be targeting priority populations for HIV prevention. And this next table is showing more demographics. We'll start by discussing income. So we stratified the self-reported income as either less than $20,000 per year or greater than $20,000. And amongst repeat observations, there were more people that reported having an income less than $20,000. So it's 24% versus 21%. We also saw a difference in the distribution of where people, where the zip code was that people reported living in, and where the home test was received. And there was less people in Manhattan, and what we saw was more people in Queens, actually, that had been a repeat participant in the home test giveaway. And similarly, we saw a difference in insurance status, where repeat participation was associated with having being uninsured. So 67% had health insurance in the repeat observation group compared to 77% in a new observation. So next I'm going to describe some of the sexual health characteristics that I was specifically interested in looking at. So the first are provider visits. So we ask in the follow-up survey these questions that are specifically asking about the 6 months prior to the HTG wave. So first do we ask people if they've had a provider visit in the past 6 months. And amongst repeat observations, there was overall less 6-month provider visits as opposed to someone who was participating for the first time. So it was 59% versus 68%. And we also saw a decrease in STI testing as well. So this is self-reported STI screening in the past 6 months. And amongst repeat observations, it was 48% versus 55% in the new observation category. And interestingly, there was just a small increase in actually STI diagnoses self-reported in the repeat observation group compared to the new observation group. But it should be noted that the effect size here is much smaller than the other findings. But these were all shown to be significant using a chi-squared analysis. So then we also asked participants if they'd be willing to pay the retail price for a home HIV self-test. And it is quite expensive. And we saw that from the overall HTG, a lot of participants would not be willing to pay the full retail price. And we were curious to see if there was an association with whether people had been repeatedly joining the HTG. And we did see that repeat observations were associated with people reporting not willing to pay the $40 for the self-test, which I think just goes back to the fact that this could be providing a service to people that either would benefit from it more or potentially don't have the resources to pay for a service like this on their own. And this next slide is showing HIV-related behaviors, again, looking at a 6-month period prior to the present HTG wave. And what we saw overall was pretty much that there was similar reported HIV-related behaviors amongst both repeat and new observations. There was slightly less condomless sex in the past 6 months reported in the repeat observation group. But again, this is a small effect size. But given the large sample size, this was significant on the chi-squared analysis. So I think this is something that we can further address as we have more waves of the HTG. But across the other categories, so sex with a partner who is living with HIV, transactional sex, and IV drug use were overall low, but they were also similar across these two categories. And then we also looked at self-reported PrEP and PEP use, and these also were similar across both categories of repeat versus new observations. So the limitations are similar to what Zoe mentioned for the overall analysis of the HTG data, but I'll emphasize a few that I think are important for this specific analysis. So the first is that the repeat participation, so the criteria included participation in any of the waves, and it doesn't account necessarily for time between waves. So one of the sensitivity analysis that I'd like to do would be to look at participation in either consecutive waves or maybe just look at participation within maybe 1 or 2 years. Because, for example, this could include participants who joined wave 1 and didn't join again until wave 7. So that's one of the limitations. And the other limitation that should be noted when analyzing this data is that we don't have any longitudinal information on those who did not repeat. There's not a longitudinal comparison category. So what we can also do is, as we do information on more waves, we can help answer these questions better as well. And we don't specifically recruit for repeat participation. So, the people that were falling in this category, they could be subject to into different various biases. And the other patients are similar to what we saw for the main HTG. So in summary, repeat participation was common amongst HTG participants, and over 1,500 participants who were deemed an HTG code participated in 2 waves, and over nearly 600 people participated in 3 waves. So it's very common overall. And what was very interesting was that it seemed to be that we are targeting, or at least providing services to higher risk and priority populations, including Black or Latina ethnicities, and as well as people who are reporting lower income and not having health insurance. And that 6-month provider visits and STI testing were also lower in the group that had been joining the HTG on multiple occasions. And then also just in terms of HIV related behaviors, they were actually similar across both groups. So our next steps is, first of all, to do further analyses looking at within participant trends. So we would be able to potentially follow people across the waves, especially if they participated in 2 or more. And we could actually do within subject analyses looking for trends and possibly identifying associations or even potential outcomes associated with multiple participation. And again, as I mentioned before, doing a sensitivity analysis, looking at subsequent wave participation only. And I think one of the major next steps is just to help us brainstorm on how to better serve the HTG population and the people utilizing the service. And what this shows was that there's a deficit in STI screening. So I think just exploring novel methods to link our HTG participants with sexual health services, I think is critical. And this could potentially involve either home STI screening or potentially trying to link participants with services throughout the city. So I just wanted to thank the Bureau of HIV, the HIV Prevention Program, definitely the ICAP Global HIV Implementation Science T32, and the Columbia University Division of Infectious Disease, where I was a fellow while working on this project. And I'm happy to take any questions.
Thanks, Lawrence. A question from Gina Wingood. Did you see any evidence of risk compensation that is engaging in risky sexual behaviors as a result of repeat participation?
Yep. So as I reported, we actually saw similar sexual health outcomes across both of the groups. But that is one thing that we were specifically interested in, especially as this has been in the discussions revolving PrEP also. But I think one thing that the data showed is that it was actually similar. What we saw was would appear to be more so like less access or utilization of sexual health resources.
It'd be interesting if you could actually look at diverse subpopulations to see if there's differences between diverse subpopulations in those findings. Because you're right, overall, it might be, there's no difference. But when you break it down to diverse subpopulations, you might find differences.
Yeah, that's a great suggestion. Absolutely.
Lorenzo Williams asks, do you all see any challenges with health illiteracy?
I mean, I think that's a challenge. I think with any program, especially of this nature, that's providing services citywide. I think we do our best in terms of education and the materials that we give participants. So, for example, when we send the kits out, they do have sexual health materials. There are resources on PrEP and other sexual health information that we do provide, but I think it's something that needs to be considered. And then I guess specifically looking at this in terms of like what I was studying with repeat participation, I think it is very important if we are able to identify people that are really utilizing this HTG. I think an issue like health literacy should be something that we consider if we can identify them, but also to attempt to provide better services targeted for that population.
We have a comment from Devin Price. Given the STI testing and treatment results, it seems like this program is reaching folks who would absolutely benefit from a home-based STI testing kit as well. Very interesting data.
Yeah, we definitely agree. And I think this is something that in the setting of the COVID-19, I think pretty much every sexual health clinic can attest to this, that we need to strategize and I think be flexible in how we are providing sexual health testing. So I think this data just informs this whole situation that we're in right now. And I think there's definitely things we can learn from the home test giveaway and potentially look at mechanisms to help provide home testing for STIs. I think it's definitely a topic of interest.
Sorry, we were chuckling a little bit because we are also working with Devin on that question. So this is a great reason to keep going on that. We have a project, the burgeoning project, working with her and Dr. Sarit Golub in this area.
We have a question from Phil Kroniski. Could you speak to how this work might apply to different age groups and specifically youth?
Yeah, so the home test giveaway is limited in terms of age, so to 18 and older. But I do think that a service like this could be interesting to see how it would be utilized in an adolescent age category. But unfortunately, with the nature of our inclusion and exclusion criteria, we don't have any data for younger ages. The average age was, it was around 30 across all the waves. So I think we can speak to that age category, but it's hard to say in the other extremes, whether that's like the older categories or adolescents.
I think you just answered JSC's question. So let's move on to Lorenzo Williams. How many false negatives are reported as well as false positives?
Yeah, so the one caveat anytime we're talking about the positivity data in the HTGs, and this is all self-reported. So if you look at the completion rate for the follow-up survey, as Zoe presented, clearly not everyone is providing this information, and that also they have the option not to respond to the question of what was the result of their test. So I think we have to use a grain of salt when we're looking at false positivity or false negativity or even true positivity results from the home test giveaway. We can report that there are participants who did test positive within the home test giveaway, and I did find some that tested positive who had participated in multiple waves. So I think that part's interesting, but we would have to we'd have to look more closely to really identify false positives, false negatives, and really get a sense of did they have their confirmatory testing, and to really answer that question.
If I could add, I mean, with this many tests sent out, even if it's a rare occurrence, we have seen false positives, folks going to get tested for confirmatory. It's very rare. But that's also, what the statistics show about this particular test. It's a rare occurrence, but it does happen. So that's why we obviously tell people to get their confirmatory test and do what we can to make that linkage as much as possible. So if people are saying that they haven't gone for a confirmatory test, we ask them if there's anything we can do to help, and give them several different options of ways to contact them. And then also, if there does happen to be a false positive and folks want to talk to us about it, we have had at least one instance where we did talk to a participant about it to talk about what happened. We haven't yet mentioned it, but another thing that both Lawrence and also our colleague Paul Kobrak is working on is a qualitative study of those who do have a positive result within this program. Overwhelmingly, even though this may not be the news that they were looking for or hoping for, they actually have a very positive attitude towards the giveaway itself and towards self-testing still. Many found that this is the type of testing that really got them to test. They really wanted the privacy and potentially the not having to go into the clinic for a variety of reasons.
Yeah, and just to piggyback on that too, that in many of these interviews, we were wondering if people would have difficulties receiving the self-diagnosis at home. And actually, from the limited number of interviews that we did, that didn't seem to be a problem. And so I think that was reassuring as well.
I think in the interest of time, let's move on to our final presentation.
Can you see that?
Yep.
Perfect.
Thanks, Maria, and thank you to Zoe and Lawrence. So hello, everyone. Thanks so much for letting us come and speak to you today virtually. I'm Stephanie Hubbard. My pronouns are she and her. And as mentioned earlier when I was introduced, I'm the Director of Program Planning for HIV Prevention at the Health Department. And I'll be presenting with my colleague, Maria, who will introduce herself.
Hi, everyone. I'm Maria. My pronouns are she, hers, and I'm a senior program planner in HIV prevention as well.
Okay, today we'll talk to you about how we've adapted and implemented the community home test giveaway virtual program earlier this year in the response to the changing community needs due to the COVID-19 pandemic. And one thing, we actually see some of our community home test giveaway partners on this call, so shout out to you all. It's so lovely to see your faces. As I'll mention soon, this program does not happen without our community partners. Next slide, please. So leveraging the successes and lessons learned from the program Zoe and Lawrence just presented on, the prevention program launched the community home test giveaway in 2017. And where we really partnered with agencies in New York City to promote and distribute HIV self-test to support both HIV testing kind of in general, as well as self-testing more specifically. Currently, as you see on the slide, the program has gone through 3 distinct phases. Phase 1 launching in 2017, then with really strong partner involvement, we revised it a bit to be more client-centered, and so then launched phase 2 in 2018, and we are currently in the 3rd phase, which is what we're calling the virtual program. And so no matter which phase of the program we're in, our CHTG partners are the cornerstone of the CHTG model, as the program leverages the partner's experience and reach with priority populations that we aim to serve, which you'll see on the right-hand side. And as I mentioned before, we are nothing without our community home test giveaway partners. They are the reason there have been multiple iterations to be as client-centered and friendly as possible, and they're the reason why we have seen success with it. So just major shout out to them, and thank you for some of you for being here today. Next slide. So how did we get to phase 3? Well, in March, the COVID-19 pandemic really exacerbated the need for HIV self-test as a testing option, and also underscored the importance of establishing an HIV self-testing program that could be operated virtually. And when we thought virtually in all aspects, so that could be implemented and received from your couch. So in response, we developed and launched the Community Home Test Giveaway virtual program by adapting previous iterations, really leveraging phase 1 and phase 2. And more importantly, leveraging the strong relationships that we had developed with our partners. Next slide. So the virtual program expanded our existing CHTG programs membership to include more health providers, so hospitals, clinics, community centers, as well as CBOs and small businesses. And because of the expanded partnership, the virtual program really supports general HIV testing and also HIV testing as a part of PrEP and PEP service provision, and really a strategy that many clinical sites have implemented during the COVID-19 pandemic. So with that, I'm going to hand it over to Maria to walk you through the program a little bit more and some of the data that we've been collecting.
Great, thanks, Stephanie. Great, so before we jump into it, I'll just describe for you what the CHTG virtual program actually is. The program model is just 5 steps. CHTG partners promote the program, ask people a few demographic questions, collect the responses to those demographic questions, provide their client with a code to redeem a free HIV self-test kit, or nowadays, as agencies have opened up, they've been able to provide kits directly to clients sometimes. And then lastly, agencies send the client a link for an opportunity to complete a client experience survey at a future date. So these 5 steps can really take place in the span of a 30-second or 20-minute interaction. They can be virtual, or they can also happen in person now, as agencies are providing in-person services. And it can be short. If someone just reaches out to an agency interested in a free HIV self-test kit, or it could be part of a larger education session that agencies are having with their client. It really depends on how the agency chooses to integrate this program model into their existing activities, and it can vary based on the services the agency provides and their current capacity. So to put everything into context, we really began developing this program model in late March, and about a week later in early April, we launched. And the reason we were able to develop and launch the program so quickly was because of the existing iterations of the program that Stephanie mentioned earlier, in which we had already conducted so much of the community engagement and received really valuable feedback. We also have longstanding relationships with many of these agencies, which facilitated a much quicker application process into the program. So since April, we've continued to conduct technical assistance and shared lessons learned with all the partners through all partner Zooms in May and August, and we have another scheduled for December. So the CHTG virtual program has a total of 73 partner programs, which represents about 66 unique organizations in New York City. One organization can have multiple programs in the CHTG because they operate so separately from one another. The graph here shows the breakdown of organizations by type. So about a little bit more than half are non-clinical from community-based organizations, as seen in the blue color. And then the other half, about the remaining 42%, are from hospital, community health centers, college, and they would be college medical centers. We have one medical office and a nonprofit research site. And we also wanted to take a second here to highlight some of the work done by CHTG partners to showcase how quickly they've really adapted to COVID-19. Beginning in April and really throughout the entire pandemic, CHTG partners have been promoting the program online. So here are some of their creative posts on Twitter and Instagram. We've got one from ACQC, Harlem United, from Canva, from HCC, and GMHC. And these are just a few of the many that are out there online right now. And it's really wonderful to see how everyone took some of our resources and templates and customized it for their own social media and tailored it for their own priority populations. Okay, so now I'll jump into a little bit of our CHTG data. This data is based on the data collection tool and the data we've collected from that tool that I mentioned in the program model earlier. So agencies ask the clients a couple of demographic questions. It's just 6 demographic questions, and then they submit those responses to us through our system. So this graph shows the total number of codes and kits distributed by all CHTG partners, and it's separated by redemption status. This data goes from since launch April 2nd to about 2 weeks ago, November 4th. And so in total, you can see that they've distributed collectively more than 2,300 codes and kits, which is amazing. And then on top of that, over 2,200 of those codes, as seen by the blue line, have been redeemed. And then we have 171 codes, as seen by the pink line, that has yet to be redeemed. This graph shows the number of HIV self-test codes and kits distributed by month, broken down by agency type, so clinical versus non-clinical. So the general pattern we see here is that in April and May, we see the distributions increase dramatically as partners began to implement the program and they were ramping up. When we entered the different phases of reopening this summer, we saw a dip in the number of codes and kit distributions overall, and that happened in June, as many partners adjusted to the new reopening guidance. And we actually want to zoom in on this a little bit, because what we see is that within the month, by week, there's actually a lot of variability. So this is the same graph, but now broken down by week instead of month. What we see by week is that as phase 1 and 2, as you can see in early June, distributions among clinical and non-clinical sites dipped as agencies adjusted to going back to the office and resuming some of their other services. And as the weeks went by, as you see in kind of later July, by phase 3 and 4, the numbers have started to increase a little bit as people adjusted to their new normal. What we also see is that in clinical and non-clinical sites, that they use the program differently. And this is also backed up by what we hear in the all partner calls from the agencies when we discuss this data. In the beginning of the pandemic, clinical sites rapidly implemented the program and accounted for most of the distributions, as you can see it by the blue color kind of in the April and May part of the graph. And as the reopenings occurred and in-person services like clinical testing services could resume, distributions by clinical sites decreased and have remained at a lower number than previously, while non-clinical sites have held a bit more steady throughout the entire pandemic. And that's shown by the pink there. So who have we been reaching through the program? Based on the demographic data submissions, we know that the CHTG programs are reaching our New York City priority populations that Stephanie flashed earlier. Agencies have provided codes collectively to more than 1,800 Black and or Latino individuals, which represents 76% of everyone who received a code or a kit. We're also doing a really great job of reaching MSM, TGNC, and women, specifically reaching a large percentage of Black and Latino individuals from each population. And what's really interesting about these trends of they've held steady since the beginning of the program. Our partners have continued to reach New York City priority populations throughout the pandemic. And we don't have an eligibility screener in the program. You might have noticed in the program model that we don't have that. So the fact that we are reaching our priority populations is a testament to our partner agencies' expertise, their experience, and their reach. In the data collection tool, we also collect the age of clients. So the average age of those reached by the program is 33 years old. The median is 30 years old, with the age range really going from 15 to 74. And you can see the distribution in the graph here. We also collect zip code of residence information. This is self-report. So CHTG partners are reaching individuals who reside across New York City, most of them in the Bronx, followed by Manhattan, Brooklyn, Queens, and Staten Island. We also have 4% report residing outside of New York State. So these are typically folks who reside in neighboring states like New Jersey, Pennsylvania, and Connecticut. And 4% also reside out of New York City, but within New York State. So those would be Long Island and upstate. For those who have a test kit mailed to them, we also collect information on where that kit is sent to. So we see a similar pattern as before, with most individuals having kits sent to the Bronx, Manhattan, Brooklyn, Queens, and Staten Island, as well as a few kits sent out of state and throughout New York. Lastly, the health department does also separately fund some clinical sites. So for those clinical sites that are funded and also a part of the CHTG program, they are asked one additional question in the data collection tool as to how they're using the HIV self-test kit. So whether it's part of their delivery of PrEP and PEP services or just part of general HIV testing. And so the subset of clinical sites report that 71% of test kits distributed by them are for PrEP services, 6% are for PEP, and 23% are for general HIV testing. So in summary, CHTG partners have adapted quickly and implemented the virtual program shortly after the pause in March. Clinical sites began integrating HIV self-tests into their PrEP and PEP flow, whereas non-clinical agencies also adapted their services to including offering of HIV self-tests to clients, particularly when more in-person testing and mobile testing wasn't available. An offering of HIV self-testing to patients really allowed CHTG partners to expand their tool belt, allowing patients to access HIV testing in different ways. More options means that we're empowering patients to choose the option that works best for them. And it's also another innovative way to continue to reach patients during the pandemic. I want to thank you everyone who has been involved in the development and the launch of the program. Rose Island in particular is our CHTG team member who couldn't be here today. Dr. Ben Choi, Dr. Julie Myers, Amanda, our wonderful HIV prevention TA team, and of course our CHTG partners. And thank you. If you have any questions, feel free to email us, and we're here to answer any questions here as well.
Thank you both. If there are any questions, please enter them in the chat or feel free to unmute yourself and ask away.
Hi, this is Lorenzo Williams. I had asked the question around the age limit. In the literature, it says you have to be 17 and older to take the test. I was wondering if a parent could use the test to test their kid. It doesn't say in the literature. And I know that the HIV rate to take an HIV test in New York is what, 13 or 14 or something like that?
Yeah, so the new testing law, or not so new anymore, allows for minors to access testing without a parent. We don't, as the HIV self-test is actually FDA approved for 17 and above, and it's FDA approved to be taken, by the person that's actually, administered by the person taking the test. However, one thing that we do is to support those agencies and adolescents, we don't actually we collect age data just for our own distribution information. However, we don't make it an eligibility requirement. We don't actually require agencies to look at age of the client that the test is being distributed to. And we actually worked with OraSure. We had a previous partnership with OraSure and Walgreens where they were able to go take a card into Walgreens and purchase a test kit for free using the card. And Walgreens had originally had a kind of alert pop-up that asked for age and identification of to kind of card someone for the test, and we were able to successfully get that to be removed so that there was more access to the test in general. So you will see our numbers there are some that are below 17, and this is just really to support HIV self-testing more broadly.
Good morning, everyone. David Matthews here. Hi, Stephanie. So one of the things that I've kind of been, I guess, questioning around this is that there was some data around the understanding that individuals who were engaging in transactional sex or sex work were taking advantage of the test kits. What if or was it at all even recommended or suggested as part of this process? And then kind of how was that managed in the data? If individuals who are engaging in sex work were utilizing the test kits to test their partners or to test their customers, if you will. And how was that potentially taken into consideration, seeing that there was a good number of individuals who were repeating, requesting the free test kits? what if those individuals are utilizing them for their customers?
Sure. So I'll answer it from our perspective, and then I can also hand it over to Lawrence and Zoe to answer that question from the online version. So one of the really neat things about working with partners out of the community home test giveaway is that we get a lot of anecdotal information back from them, right? Because the neat thing about HIV self-testing and the way that we've run the giveaway programs is that it's really autonomous, and you can also be quite anonymous as well. And so the information that we get back is only as good as how many people fill out the follow-up survey or anecdotal information that we get from our partners. So a lot of our CHTG partners have talked about how their clients have utilized testing in exactly the way that you just mentioned, amongst clients during sex work, amongst their own partners, amongst new partners. They'll bring a test over before they have sex with somebody. And so the neat thing is that it can be utilized in various different ways, and folks are using it and utilizing it in ways that work for them. So we are perfectly fine if folks want to take a test kit for somebody else. And actually, I believe both in the program that Lawrence and Zoe talked about, as well as our program, we ask, did you use it? Or did you give it to somebody, have them use in the follow-up survey, so we can get a little bit of that data. And Lawrence, do you want to talk about if any of that information showed up in the repeat testing?
Yeah, so exactly as you mentioned, we do ask participants how the test was used, and the vast majority report using the test for themselves. But then there is a small percentage of people who do report using it with someone else. And then we ask them, was this person a sexual partner or not? So within the data, I mean, it is clearly limited by some biases and just the overall nature of how we're asking the question, but we could stratify based on the people who are reporting transactional sex in the past 6 months and look at those variables. I think that's a great question. And it goes back to kind of what I mentioned too, that even though the overall percentage was fairly low of people reporting transactional sex in this year, and then looking at gross numbers though, it's over 100 people. So it would be great to be able to further characterize how the test is being used with them.
Yeah, thank you for that, Lawrence. And I'll just add, I think it's about on average by wave, 5% of folks reports giving it to either a friend or a sexual partner. So we can certainly dive deeper into that. And the idea of further expansion of HIV testing in that way is a very interesting avenue. And we definitely want to make sure that those who need a test are getting it. So that's something we want to measure and look into.
Feel free to unmute yourselves if you have any other questions for the team.
Hi, this is Victoria Fry. Excellent, wonderful presentation. Thank you all so much for all of your work and putting it all together in one place for us to consume and understand. I'd absolutely love to get the PowerPoints. I'm wondering if there's been any thought to combining HIV self-testing with other STI self-testing or self-screening approaches that would address multiple needs for sexual health, self-screening and self-testing.
Yes, I would say that's something that we're looking into with the online giveaway. We have some formative data that we're not ready to share, but was collected on the last follow-up survey. So we're starting to do the formative research for that. And I'll just pass it over to my community home test giveaway colleagues on how that's incorporated into their program.
Yeah, so I think the biggest bummer for us all right now is that we don't actually have STI self-testing options, only specimen collection options. So I think right now what we're trying to figure out with our community partners is how much of a burden does that place on the client, and how much does the client still want to be able to do the self-collection themselves, and figuring out all the different options. We actually had an all-partner meeting at the beginning of this year in February, where we talked about what implementation would look like with our partners. What are some of the, we actually showed various different manufacturer self-collection options, looking at the instructions. Someone asked about health literacy earlier, looking at the instructions, is it clear, what other information would they need? And, that has been really helpful to understand how we might implement something like this. I think one of the biggest, and Maria, feel free to chime in, one of the biggest barriers that they identified is that some of the literature was really not gender, was not inclusive and not affirming for gender nonconforming folks and people of trans experience. And so I think there's some of those implementation logistics to be worked out, but also very, very, very much interested in creating it as an option. And Maria and I have been joking a lot about having some sort of, sexual health kit in a box where like confetti comes out and there's lube and there's sorts of fun stuff that you might want to add to your sexual health experience, including HIV self-testing and, STI self-collection, and hopefully STI self-testing when it does come out on the market.
This has been, I think, another challenge. Sorry for jumping in late and also missing the team's great presentation. I was stuck doing COVID, but really appreciate all the hard work they've done because it's been amazing, their ability to provide services. I think one of the big challenge for us is that for STI testing, New York State regulations on testing is much more stringent than other states. And that has been our big issue in terms of, because you need a physician's order to do that. That has been a challenge, that an option that's available in other states that's currently not available yet in New York.
I just wanted to let you know, I know you probably know this, Christian Grove is doing a big study that involves a lot of, specimen collection, self-specimen collecting, and so probably has really good information on, and I've seen some of the videos they prepared to help people, and they're very sex positive and appropriate.
Hi, this is Paul Richards over at New York Presbyterian Columbia. Yeah, so we actually did a pilot project during COVID regarding STI at-home collection. So it's doable. It's a thing. It can happen. But yeah, to the point of New York's self-collection at-home STI testing guidelines are stringent, to say the least. Is definitely a thing. So obviously, if anyone has anything out there that they know of that can jump over some barriers, please do let me know.
Lorenzo, are we distributing the COVID home testing kit, Sophia? And if we are, what impact is that having on this program?
We are not, as a part of this program, we are not distributing COVID home tests.
Jay, I see you have your hand raised. Feel free to unmute and ask your question. If not, anyone, again, feel free to unmute to ask away.
Can you hear me now?
Yes.
Hey, I'm sorry. I thought I was on muted. Yeah, good morning, everybody. Thank you very much. I think this is really great. I'm asking is that, did you separate sent test out to? How many of those may have you sent the test to and decided at the last minute not to take the test? Now, how do you re-engage those people? How do you get them to take this test? I mean, a lot of time, energy, and money is going into it, and I see a lot of waste if they don't take the test, and we can't get them to take that test.
Thank you for that question. We have information on people who who took our follow-up survey, who got a test and had not yet used it. And overwhelmingly, the majority state that they plan to use it. So I would say, at least among that population, I don't think that there is a lot of waste. I think the test is, if not yet used, will be used. And really the overwhelming majority of at least those who take the follow-up survey, overwhelming majority have stated that they've already used the test, and most use it right away. So I agree with you that it's important for people to test, but I think that, as I said, most people are using the test or are planning on using the test that they receive.
Yeah, but this is a being that this is a study, right? Is it not like a time limit on this?
There's no time limit to use the test within our program. People receive it and can use it voluntarily whenever they want. There is, I believe the test is good for 2 years. I'm not entirely sure about that, but there are expiration dates on those tests, but no one is required to use the test that they receive. It's, voluntary.
Yeah, and thanks, Zoe. And I would just add for the CHTG program that we see similar results in our follow-up survey, that overwhelmingly folks have either used the test already, because we send the follow-up survey about 6 to 8 weeks after the initial contact with the agency to give people time to use it. So overwhelmingly, people have reported that they've either used it or given it to someone else or plan to use it. And of course, that is our follow-up survey, so it is just a subset of folks. In the CHTG, it's nice because they have the connection to agencies. So lots of agencies are conducting just a phone call a week or two after speaking with the client, just to see how they were doing and to offer any sort of follow-up services or any support that they might need. So we do see similar trends as HTG.
And to get the kit through you have to belong to a medical facility?
No, it's any of our community partners. So whether it's a community-based organization, it could be a health facility like a participating hospital or clinical site or community health center. We have some colleges as well in it. So you just have to reach out. They're actually on our DOHMH website. So anyone can just reach out to them and just answer a couple of questions, which are actually voluntary, and receive a free kit.
Right, but that means you have to belong to some sort of medical organization, institution. In other words, if I'm just a guy standing on the street corner and we're talking about this, and I say, you know what, here's a link, here's an email address, contact these people, and they'll send you a free kit. I mean, how are we engaging those people?
That's a really great point. So that is actually what can happen. Right now, many of them are doing it virtually. So standing on a street corner, hanging out on Grindr, on Facebook, on Instagram, at a virtual event that an organization is having. And right then and there, they can promote the HIV self-test and actually can get them linked right then and there to ordering the test kit themselves to their house. And then, as we mentioned, if they prefer to go, if they're actually at the small business, at the CBO, at the clinical site, whoever is the partner, if they're on site, they can actually get the test right then and there as well. So it's exactly as you're discussing, and I think that's the neat thing about partnering with our agencies for the community home test giveaway, and then also the great work that Zoe and Lawrence is doing. It's multiple different avenues of engaging a variety of different populations who are interested in getting an HIV self-test or are actually learning about the option of an HIV self-test for the first time, and then making sure that they are able to get it in hand in the way that works the best for them.
I also wanted to add there's a lot of variety in the type of HTG participant that we see. So for example, we also ask people if they're testing elsewhere using other modalities of testing. So for example, going to a clinic for testing, and we see responses across the board. Some people have never tested in their entire life. some people are actually just using the home test as part of their routine testing schedule. And I think everyone has different HIV testing schedules. And when we're seeing that across our programs.
Thank you everyone for your questions. Now I'll turn it back to Bob Remien for closing remarks.
Thank you, Stephen, and thank you, everyone. This was really, I thought, a fantastic panel, fantastic day. Thank you so much, Zoe, Lawrence, Stephanie, Maria. Oh, you all did a great job. And we had great participation today. We had over 90 people attending, which really pleases us. Thank you, Teo Sanford and Stephen Sukumaran for organizing this event. Thank you, Stephen, for your masterful moderation of the discussion.